Hi there, this is Dr. Parsons coming at you not so live to discuss the remaining pediatric renal tumors that we see. If you haven't listened to the Wilms tumor mini talk, it might be a good idea to listen to that just because it talks about the most common renal tumor that we see in children. And can give you a little bit of a context for some of the findings that I'm going to discuss in these other tumors and why those findings make it the tumor that we'll be discussing and not a Wilms tumor. Another thing that was discussed in the previous one is staging, and staging for all pediatric renal tumors minus renal cell carcinoma is the same. So it's a good idea maybe to take a gander and listen to that, just to, again, familiarize yourself with the staging system that's used in pediatric renal tumors that are not carcinomas. So we're going to discuss today the tumors that you see on the screen. Congenital mesoblastic nephroma and its major variants, clear cell sarcoma, of kidney, rhabdoid tumor of kidney, renal medullary carcinoma, and XP11 translocation renal cell carcinoma. So we're going to transition over to our slides. We're going to start with our first entity, which is congenital mesoblastic nephroma. So congenital mesoblastic nephroma is the most common renal tumor of infancy. Note that I didn't say childhood, I said infancy. So if you are given a clinical scenario of a young child who's maybe 2 months old with a large renal mass, your very first thought ought to be congenital mesoblastic nephroma, because that is what's going to be the most common in that age group. So right now we're at the interface between the normal kidney, which you can see down here in the lower right corner, and the tumor that's up here in the upper left. One of the things to note right off the bat here is that there is no fibrous pseudocapsule that's separating the tumor from the more normal appearing kidney. That's an important distinguishing factor of this tumor from, say, a stromal predominant Wilms tumor. Wilms tumor should always have, or almost always, virtually always, have that fibrous pseudocapsule at least in some area. And this tumor really doesn't. It's, kind of blending in and percolating in between some of these tubules. And you'll see maybe some other areas where it really just sort of blends and is somewhat infiltrative. So let's take a gander over here at the tumor itself. On low power, hopefully you can appreciate that we've got some entrapped normal renal elements surrounded by this sort of spindly looking process. So let's get a little bit closer and take a look and see what we can find. So up on higher power, you'll notice that the tumor cells themselves are spindled with elongated nuclei. There are mitotic figures around, but don't let that scare you too much. In some areas, it has somewhat of a fascicular pattern. So for example, these are tumor cells that are kind of coming right out of the screen at us, whereas these are running alongside. Almost gives that appearance of like a leiomyoma or a leiomyosarcoma. Again, I think it's important to notice that there are entrapped tubules here, entrapped elements, but these are not a part of the tumor themselves. They really are just sort of innocent bystanders that have been caught up in the tumor. So don't mistake this for an epithelial component in a Wilms tumor. Now, if you were thinking about Wilms tumor, you'd be thinking about a stromal predominant. But again, the lack of that fibrous pseudocapsule is one good hint that you're not dealing with that. The patient age range is also not awesome for Wilms. It certainly happens, but less frequently than does congenital mesoblastic nephroma in this particular age group. So This is the so-called classic variant of congenital mesoblastic nephroma. It kind of looks a little bit like, some people say, like an infantile myofibroma, if you've ever seen one of those. It's kind of interesting because this particular class of tumors really recapitulates soft tissue tumors that occur in children, two very specific ones. And infantile myofibroma is one of those that this tumor kind of mimics. As you may have seen earlier on a bit of a higher power, the mitotic activity is, it's not low, and that's okay. Don't let that freak you out too much. Get ourselves into focus here. In some areas, the nuclei look a little bit more ovoid or rounded. I think it depends a little bit on what plane you're seeing those tumor cells in. But this is essentially what the classic variant of congenital mesoblastic nephroma is. Now, this is not the most common, even though it's called the classic. It's kind of funny. The more common variant of congenital mesoblastic nephroma is what's called the cellular variant. So we're going to take a peek at this example of a cellular variant. And so out here, we don't have so much normal kidney, but we have the outer surface of the nephrectomy specimen that's inked in black here. We've got some perirenal fat. And then here we've got the renal capsule. So this is the capsule of the kidney. There's a few renal elements that still remain, but this doesn't really look encapsulated. And, in areas it's kind of just blending with the capsule, but it's not going through it. It's this one, compared with the cellular variant, is a little bit more well delineated, if you will, but it still doesn't have a distinct fibrous pseudocapsule like our Wilms tumors do. Again, we can see that there are some entrapped renal elements, some little tubules in there. Again, important not to mistake those for part of the tumor. They're just unfortunate bystanders who got caught in the mix. Here at a slightly higher power, hopefully you can see that these tumor cells, by comparison, maybe are a little bit more, have more ovoid nuclei as opposed to spindled. It's still fairly mitotically active, but we'll get in a little bit closer to take a look at that. And it doesn't really have the same architecture or patterning as the classic variant did. It's a little bit more sheet-like, if you will. It doesn't so much have that fascicular pattern that we saw before. But it is quite cellular, hence the name. Getting a little bit higher power here. We've got a few intermixed inflammatory cells, some vessels in the background, because this thing needs blood to survive. And then there are scattered mitotic figures around here as well. And again, that's okay. We don't freak out about the mitotic figures. This tumor is allowed to have those. That's all right. It can be actually pretty briskly mitotically active, this particular tumor. But again, don't let that freak you out too much. It's just a feature of this particular tumor. Now, there really, unfortunately, are not a lot of great stains that can help you with either of these variants. But remember when I said before that both of these variants kind of bear similarity to two distinct soft tissue tumors that we see in children? Well, the cellular variant of congenital mesoblastic nephroma actually looks quite similar to infantile fibrosarcoma, which is a tumor that occurs in very young infants, usually on the extremities. While it tends to be kind of locally invasive, its metastatic potential is generally pretty low. And that actually tells the story of congenital mesoblastic nephroma as well. These tend to be kind of infiltrative. They tend to be more at risk for recurrence rather than metastasis. And the thing that these two tumors share, that infantile fibrosarcoma and congenital mesoblastic nephroma share, is a translocation involving ETV6 and NTRK. And that's a 12-15 translocation. So just tuck that away in the back of your head, because sometimes certain examinations like to ask questions about different entities that share the same cytogenetic abnormalities. And so congenital mesoblastic nephroma and infantile fibrosarcoma are one of those. They have NTRK translocations. one of the reasons that matters to people, other than being very helpful for us as pathologists who are trying to make this diagnosis, there are NTRK inhibitors that are currently on the market. And hopefully those will show some efficacy in kids who maybe don't do as well with surgery or need to have some therapy before surgery because of tumor size. But anyway, so that's really important about this particular tumor. That translocation is not present in the classic variant, which is kind of annoying when you're trying to make the diagnosis. However, it is really helpful when you've got the cellular variant. So if you've got a tumor that looks very stroma or sarcoma-like, that is occurring in an infant, in a very young baby, 1, 2, 3 months old, up to about 6 months old, definitely consider sending that for FISH testing for that 12-15 translocation. So I think that's probably all we've got to say right now about congenital mesoblastic nephromas. We'll move on now to a different tumor. And I apologize in advance that I do not have actual slides for this, unfortunately. But we're going to talk a little bit about clear cell sarcoma of kidney. So clear cell sarcoma of kidney is a really, really uncommon pediatric renal tumor, but it's very important to recognize in part for prognostication. This is a tumor that tends to be very aggressive and has a real propensity for metastasis. And once upon a time, it had metastasizing renal tumor bone, or had a name that was similar to that, which really described its behavior. And this tumor is also really notorious for coming back and metastasizing many, many years later. So for example, there have been instances where patients have had a, quote, renal tumor removed when they were young, and then they come back as young adults or even in their 30s, and now they have metastatic tumor all over their lungs. And unfortunately, that is sometimes how clear cell sarcoma of kidney behaves. So this is a relatively low power view of a clear cell sarcoma of kidney. And again, one thing that I'd like you to try to appreciate here from this photomicrograph is that the border's fairly well defined. Like we can see that the normal kidney is here, and then it stops, and then the tumor is here, but we don't really have a fibrous pseudocapsule. So that again should make you think, this may not be Wilms, this may be something different that we're dealing with. Another thing that this tumor kind of does is it kind of has these little infiltrating tongues of tumor, if you will, that will kind of sneak into the normal renal parenchyma. So it's maybe not necessarily on higher power quite as well delineated as it appears on low power. I think that this particular view is sort of a classic, try to remember this picture in case you ever get shown it, type of shot, because hopefully you can appreciate these little vessels that are kind of making almost a fence-like architecture, so-called chicken wire. We love to use that term in pathology. So these little vessels are kind of dividing these cells up into nests or cords almost. And this is a really, really characteristic feature of clear cell sarcoma of kidney, that you have these very thin-walled, delicate vessels that are dividing the tumor cells up into nests. We get a little bit higher and you can kind of see, again, we've got these very thin-walled vessels and these nests of tumor cells, and the cytoplasm looks kind of cleared out, as you can see. Hopefully you can kind of appreciate that the nuclei are pretty cleared out. They're not super hyperchromatic. They don't really have prominent nucleoli. We've got a couple of mitotic figures that are scattered about too. Again, pretty characteristic of this tumor. Again, this tumor, because it's kind of infiltrative, has a tendency to entrap tubules or entrap some of the epithelial elements. And one of the things that can happen when you have entrapped epithelial elements in these tumors is that you can end up with sort of regressive type changes. So the tubules will end up looking kind of immature. And that's really obnoxious because then you can really get fooled that, oh man, maybe these are immature epithelial elements in a Wilms tumor, but they're not. And I think the thing that is probably the most helpful is identifying that sort of chicken wire architecture of nests of tumor cells that are sort of surrounded by these very thin-walled vessels. That is super, super classic for clear cell sarcoma of kidney. You won't really see that much in any other pediatric renal tumor. And there are a million kind of different patterns that you can observe in clear cell renal cell or clear cell sarcoma of kidney. But at least somewhere you will find an area that looks like this. And that is when you can say, aha, I found it. Now, as far as things like ancillary studies are concerned in these tumors, it's recently been demonstrated that they are positive for cyclin D1, and that can be helpful. It's still not entirely specific for this particular entity. Another thing that can be helpful for these tumors is a pretty significant proportion of them harbor internal tandem duplications of the B-core gene. And again, this is kind of an interesting scenario of a renal tumor in children and a sarcoma having a shared molecular alteration because there are those B-core associated soft tissue sarcomas. It's this very similar thing that occurs here in the kidney. You can also see some translocations between YWHAE and NUT-M2. That's a subset of these tumors will have that translocation. I'm not going to try to pronounce it because I'll totally mess it up, but point being that there are some molecular alterations that can be identified to assist in making this diagnosis. Because these are so rare, that's going to have to go to like a big molecular center, but that can be kind of the clincher as far as making this diagnosis if you're having difficulty. Lacking it doesn't necessarily mean it's not clear cell sarcoma of kidney though, so just keep that in mind. These tumors tend to show up at a higher stage. They tend to be kind of more aggressive. Survival is not good. These get lumped into the sort of unfavorable histology realm of pediatric renal tumors. So I think we will move on now away from clear cell sarcoma of kidney into rhabdoid tumor of kidney. So rhabdoid tumor of kidney is another one of those renal tumors that I think of occurring a bit on the younger age of the pediatric renal tumor spectrum, usually from like 1 to 3 years of age. Now, this is not really anybody's favorite diagnosis to make. Unfortunately, it has a very, very, very poor prognosis at this time. These tumors tend to be fatal within 5 years in a lot of these young children, unfortunately. It's a tumor that tends to present at a high stage and is very aggressive, and also has a big propensity for metastasis. So we'll take a look here. Right now, we're looking at low power at some few remaining normal renal elements, and then we've got hemorrhage with something intermixed, more hemorrhage with something intermixed over here. So let's get a little bit closer and take a look at what we might be dealing with. So again, this is not a well circumscribed tumor. This is not a tumor that has a pseudocapsule. So right off the bat, we're not really thinking about Wilms tumor. That's not so much in the cards for us. When we get in close on the tumor here, sorry for the delay. I think one of the things that's really evident, even here, I'm looking at 10x power, there are a lot of really prominent nucleoli. in these tumor cells. And that's a bit unusual for something like Wilms. We don't really see that in congenital mesoblastic nephromas. And as you saw in the example of clear cell sarcoma of kidney, we don't see that in clear cell sarcoma either. So now we're thinking of something entirely different. Um, as we get a little bit closer, you can see that these guys are in areas, they're fairly discohesive. In some areas, they hold together a little bit better. We're going to hunt around now on higher power in an attempt to identify sort of the classic morphology of these tumors. So these tumors are called rhabdoid tumors. Now, please don't confuse that with rhabdomyosarcoma or rhabdomyoma. Rhabdomyosarcoma and rhabdomyoma just sort of have a similar cellular appearance at times to rhabdoid tumor, but they are two completely different tumors. Rhabdoid tumor is not skeletal muscle derived, so really doesn't have anything to do with it. It's just an appearance descriptor. And what it's referring to is the fact, so this is a pretty good example here, as is this one. These tumor cells have very bright pink, brightly eosinophilic cytoplasm, and they have eccentrically placed nuclei, so pushed off to the side, almost like a plasma cell. And at times you can see deeply eosinophilic cytoplasmic inclusions. In fact, we've got a really nice one right here in this portion of the field. So this is a very, very characteristic appearance for rhabdoid tumor, no matter the location. But kidney is one location where rhabdoid tumors tend to occur with fair frequency. Again, this is a very, very uncommon tumor, but it's important to know about it because it carries a very, very different prognosis from things like Wilms tumor, the majority of which end up with patients doing quite well. So again, you can kind of, I think you can really appreciate at this power the frequent, very prominent nucleoli, the vesicular pattern chromatin. These look like eyeballs staring at you. So this is a very, very characteristic appearance for rhabdoid tumor of kidney. Now, if rhabdoid tumor of kidney is anywhere on your differential when you're looking at a case, you must get an INI1. And that's really the hallmark of this tumor, is that INI1 expression is lost by immunohistochemistry in this particular tumor. So if we were to stain this, none of these nuclei would be staining with INI1. So that's an important thing to remember. This is one of those INI1 deficient tumors. And if you think about that class of tumors, those tumors tend to do very poorly. And rhabdoid tumor is no exception to that rule. When we look at these rhabdoid tumors, they often have a propensity to have many areas of vascular and lymphovascular invasion, angio invasion. Margins are frequently positive. Almost every case I've reviewed of rhabdoid tumor has had a stage 3 designation. It tends to go to lymph nodes pretty readily, and then the cat's really out of the bag. And unfortunately, as I said before, this tumor has not a very good prognosis. We can see areas with mitoses, and we can see apoptotic figures here. This is a very mitotically active tumor, a tumor that has a lot of turnover. There can be huge areas of necrosis. There can be calcifications, which I think I kind of buzzed by a little bit earlier up here. And just a quick note to say that in pediatric tumors, we often think, oh, calcifications, that sounds like neuroblastoma. But bear in mind that calcifications can be seen in a lot of degenerating tumors. So it doesn't necessarily mean neuroblastoma right off the bat. So just another area to kind of hopefully give you an appreciation for this so-called rhabdoid morphology, those nuclei that are pushed off to the side with very, very eosinophilic cytoplasm. So we're going to move on now from rhabdoid tumor to a different entity. The next entity that we'll talk about is renal medullary carcinoma. And a caveat to this is that the architecture of this particular case is not fantastic. I think in part because it's a metastasis. And the problem is that these cases are so uncommon that it's really difficult to find examples of this particular tumor because it is so uncommon. But renal medullary carcinoma is, again, unfortunately, a very highly aggressive malignancy that occurs in children and young adults, and very specifically in a subset of patients who have sickle cell trait. Not patients who have sickle cell anemia, but patients who have sickle cell trait seem to be very high risk in virtually all cases, virtually almost all cases that have been reported of this tumor have been reported in that patient population. This is a tumor that can often, when it presents, it's widely metastatic. It's highly aggressive, and again, unfortunately, these patients tend to do very poorly and succumb to their disease within a few years. Very limited reports of patients who have had any sort of survival that goes much beyond 5 years. So I think one thing that you can at least appreciate about this tumor right away is that there's a lot of lymphovascular invasion. And now this was a mediastinal mass in this patient. And so that's why we have all this intermixed fat here. But you can see tumor just hanging out in these vascular structures. So I think speaking to the aggressive nature of this tumor. Now, one of the things that we look for in renal medullary carcinoma, because it's like derived from the renal medulla, you would like to see it kind of recapitulating that medullary architecture. This tumor has totally gone off the rails and is just very high grade appearing and undifferentiated in nature. Infiltrating the fat, again, sort of similar to our rhabdoid tumor of kidney, it has very prominent nucleoli. It even has a little bit of that rhabdoid morphology in areas. So in a case such as this, where you have this really poorly differentiated, high-grade appearance, one of the things that's really helpful is to go back to the patient's history. And indeed, this particular patient, when he presented with this, he first had a pulmonary embolism. And then he was found incidentally to have a renal mass. And then he was found to have tumor all over the place, unfortunately, for this poor guy. And when history was further elicited, he did indeed have sickle cell trait. This likely represents a lymph node to which this tumor has metastasized. And this tumor is highly aggressive. You can see metastases to all sorts of lymphovascular invasion, lymph node involvement, lung masses, liver masses. Again, a highly aggressive tumor. In addition, this is another tumor that loses expression of INI1. And so if you have a renal cell or renal tumor in the context of a patient who's got sickle cell, it's definitely prudent to do an INI1. So we'll shift now into our last carcinoma, and that is the XP11 translocation associated renal cell carcinomas. So this is a low power view of an area of a translocation associated renal cell carcinoma. And kind of right off the bat, you can appreciate a bit of a papillary or almost nested type of an architecture in this area. So let's kind of hone in and get a little bit closer and see what we can see about this tumor. So right off the bat, you, I think, can appreciate that this has a lot of eosinophilic cytoplasm. These tumor cells are pretty big. They're really discreetly nested here in this particular case, which is a morphologic feature that aligns nicely with this particular diagnosis. Other areas you can find papillary architecture, And even from this low power, it's evident that there are some pretty prominent nucleoli. So we'll get down a little bit closer and take a closer peek at the cytology of these tumor cells. Again, you can see there's a lot of eosinophilic cytoplasm with these, and many of the nuclei have very prominent nucleoli. Some of the tumor cells have the nuclei kind of eccentrically placed, and that architecture remains kind of that discohesive nest-like architecture. Interestingly, or interestingly to me at least, this is another kidney tumor that has a bit of a soft tissue type of counterpart, both with respect to the appearance as well as with respect to the molecular alterations observed. So these translocation-associated renal cell carcinomas, the vast majority of them have translocations involving TFE3. That is a gene that's involved in another tumor known as alveolar soft part sarcoma. So that tumor shares a molecular alteration with this tumor. And that tumor also can kind of have this nested architecture with eosinophilic tumor cells and discohesion. So it's sort of interesting how those things line up. But just remember that TFE3 is involved in both of those tumors. And that's really the kicker in this tumor as far as making the diagnosis, because, you know, this tumor, in a lot of ways, it doesn't really have necessarily an incredibly distinct architecture, although one thing that can kind of be helpful to you is that these tumors tend to have fairly frequent psammoma bodies. And if you see some nested architecture like this with this cytomorphology in a patient who's maybe a teenager or a young adult, definitely think of TFE3 mutations. And the thing that can really help you to confirm that diagnosis is to use immunohistochemistry for TFE3. That will show nuclear positivity in this tumor, and that will really help you kind of clinch that diagnosis. There's another psammoma body. So this one doesn't have quite as many psammoma bodies as we see in some of them, but it's still pretty good morphologically for it. It's important to know that there is a subset of these translocation associated renal cell carcinomas that have alterations in TFEB. And so if you have a strong suspicion that you're dealing with a translocation associated renal cell carcinoma and it's negative for TFE3, maybe consider doing a TFEB. That may help you out a little bit. You know, a lot remains to be seen about what happens in these particular tumors and how these kiddos do. Some early information suggested that maybe the prognosis was a little bit better, but more recently I've heard from our oncology team that maybe the prognosis is really not as good as we had once hoped. I think it's important to know too, just when, you know, should you encounter one of these tumors, you're not going to want to use the renal tumor staging system that we use for things like Wilms. You'll actually want to use the renal cell carcinoma staging systems like we use in adults. So that is the remainder of pediatric renal tumors in a nutshell. Thanks very much for listening in. And if you want to reach out to me with any questions that you have, please feel free to do so via email or just stop me in the hallway and be like, Parsons, what were we talking about? Anyway, thanks so much for joining, and you guys take care.